بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. It's my pleasure and honor today to introduce Dr. Adil Ganaw. He is our Libyan colleague from Libya. He is graduated by Libyan Board of Anesthesia and Critical Care, and also the Arab Board of Anesthesia and Critical Care, and he has fellowship of College of Anesthesiologists in South Africa. Dr. Adil is a leader in educational program in Hamad Corporation and a member of research group in Hamad Corporation, and he is honored to write 24 research paper, and he is editor one book about the subarachnoid hemorrhage. Really, Dr. Adil Ganaw is a role model, and it is our forward step to have Arab and African summit of distinguished professor from anesthesia, critical care, intensive care. The floor for my colleague Ahmed Fatin to introduce the topic of Dr. Adil Ganaw now. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be with you tonight with a very interesting topic, acute kidney injury. As you know, the acute kidney injury is a very common syndrome in the critical care, affecting both morbidity and the mortality of the patient, not only in the ICU or in the critical situation, but also after discharge from the ICU. The acute kidney injury is very common in daily clinical practice. We facing a lot of patients with the acute kidney injury and with the acute renal failure in the critical care. Today, our speaker, Dr. Adil, will cover all the aspects of the topic about the acute kidney injury, about the pathophysiology, the biomarkers, the importance to recognize the early recognition of the acute kidney injury. Dr. Adil, as Dr. Safa said, he is a consultant of anesthesia and the critical care from Libya, and he is working as a consultant in Hamad Medical City in Qatar. تفضل دكتور عادل, the mic with you.
Dr. Adil, please, the voice. Please open your mic, Dr. Adil. Dr. Adil.
Dr. Adil, I think there is a problem in your voice. Can you unmute yourself?
Can you hear me now?
From the start again, Dr. Adil, please.
Yeah.
Assalamu alaikum.
Assalamu alaikum. Assalamu alaikum. Good evening, everyone. Thank you, Professor Safa and Dr. Fatin for the introduction. Thank you for all the attendants for attending my presentation. Today, we're going to talk about acute kidney injury in preoperative setting and critical care. We'll start with definition of the acute kidney injury, difficulty of early recognition of the acute kidney injury, staging. We're going to go for the importance of the acute kidney injury, review of diagnostic approach. We're going to go to a different strategy to prevent acute kidney injury, rule of the supportive care, and renal replacement therapy. We ended by contrast-induced nephropathy. So we know in the critical care we have many risk factors for acute kidney injury. That's in the critical care or operating theater. So hypotension, nephrotoxic medication, severe shock, sepsis, all these considered as important risk factor of having acute kidney injury. Acute kidney injury affects 20% of all hospitalized patients, 50% from ICU population. Acute kidney injury has serious consequences. It might progress to coronary kidney disease, renal failure, multi-organ failure associated with the cerebrovascular accident, and even mortality. So minor changes in creatinine level by 25 to 49%, double the risk of death, and increase the hospital stay by 2 days. In USA, acute kidney injury caused 220,000 deaths per year, increasing length of the stay by 3 days, and costs more than $12 billion per year. So are we dealing with very important subject tonight, and we don't have treatment for this medication. We don't have only the best thing to do to prevent and support the care. We don't have single treatment to treat acute kidney injury. So before 2004, there's more than 40 definition of the acute kidney injury. So even to have a study comparing to compare between the studies is very difficult, because you have different definition and over all the world. So 2004, the first universal definition was named rifle. They use the rifle criteria, but there's limitation of the rifle criteria here, because it's considered only, they don't consider small changes in creatinine. 2000, after that, they came with Acute that considered small changes in creatinine. Then after that, 2012, the last definition and universal definition is KDIGO. So what's KDIGO? Which is the last definition of the acute kidney injury. Increase in serum creatinine by 0.3 milligram or 26.5 micromole per liter within 48 hours, or increase serum creatinine by 1.5 from the baseline if the baseline known within last 7 days, or urine output less than 0.5 ml per kg per hour for more than 6 hours. This is considered as acute kidney injury. So, and also to stage acute kidney injury based on KDIGO, so of the increased serum creatinine 1.5 to 1.9 times baseline, or increased serum creatinine 0.3 milligram per deciliter, considered as stage 1. Urine output less than 0.5 ml per kg per hour for up to 12 hours. This is considered as a stage 1, which is mild kidney injury. A moderate, which is stage 2, increased serum creatinine from 2 to 2.9 from the baseline, or urine output less than 0.5 ml per kg per hour for more than 12 hours, as considered as a stage 2, which is more severe. Stage 3, if increased serum creatinine up to 4 milligram per deciliter, or increase 3 times from the baseline, or urine output less than 0.3 ml per kg per hour for 24 hours, or anuric for 12 hours. That's considered as stage 3. Increase the severity, increase the associated with poor prognosis and poor outcome. So if you see now, we rely only on serum creatinine and urine output to define acute kidney injury, but we have an issue here. During the surgery or during the stress anesthesia, renin and vasopressin increase a response to the stress. That cause fluid retention, so that can decrease urine output. During the surgery, only 5 to 15% of the crystalloid volume load is secreted in urine because renin and angiotensin, renin and vasopressin response to the surgical stress, as opposed to 40 to 75% in non-anesthetized patient. In acute tubular necrosis, there will be urine output is very good despite kidney damage because the renal tubule lost concentrating ability. So that is why urine output really is poor indicator of the kidney function, but it's still in the definition used for diagnosis of the acute kidney injury. If patient with chronic diuresis also might be have good urine output, but also about the kidney in damaged. The other parameter, which is creatinine. Serum creatinine increase only when GFR reduced, glomerular filtration rate reduced by 50%. So that there is delay between kidney injury and increase in serum creatinine. So it's serum creatinine lag behind for 48 hours. So you cannot diagnose acute kidney injury on time. So you see creatinine increase after 48 hours from the insult. So in addition to that, serum creatinine also can be affected by muscle mass, gender, age, volume overload, nutritional status. So also that can affect serum creatinine level and might affect recognition of the acute kidney injury. So currently there is novel biomarker which is can increase within few hours from the insult and can help us to easily recognition of the acute kidney injury. For example, neutrophil gelatinous alpha lipocholine, which is in GAL, increase after 3 to 6 hours from the insult and continue the level above the threshold of the kidney injury for almost 24 hours. The same thing for cystatin and Kim molecule as well. If you look to the creatinine, you see the serum creatinine start to rise after 48 hours from the insult. Unfortunately, this biomarker is quite expensive and not available on all the centers. Hopefully, it will become available in coming years. So now I just want to talk about why we need to focus on acute kidney injury and to prevent acute kidney injury. Just want to go for this retrospective study, describe epidemiology and outcome of the acute kidney injury in non-cardiac surgery. This is a study done in USA, the retrospective study from 2007 to 2015, included 9,311 patients, most of them male, and look for the survival, 5 years survival, 5 years mortality. So the incidence was 51%, so which is quite common. And the good thing, most of the acute kidney injury was stage 1, 34% was stage 1. Stage 2, stage 3, almost the same. And they found the most of the acute kidney injury occurs in the shock patient, either cardiogenic shock or septic shock, and more than 80% of the acute kidney injury happening in this type of the group. 45% of stage 3 ended by dialysis, and overall 3.5% population require dialysis. If you look to the 5 year survival, so if the red line here represent the above one, represent the patient with no acute kidney injury. So at 5 years, 80% of those people with no kidney injury survive at 5 years. Stage 1, almost 70% survive till 5 years. Stage 2, almost 50% will survive at 5 years. Stage 3 with no dialysis, almost 30% will survive. If patient on dialysis, stage 3, only 20% of those people will survive. So actually, the association between mortality and the severity of acute kidney injury let us focus more on prevention and optimizing patient condition to prevent kidney injury. To do that, we need to understand the pathophysiology of the acute kidney injury in anesthesia and intensive care. So in anesthesia, normally there's are multifactorial. First of all, during the induction of anesthesia, there's vasodilatation, hypotension, oxidative stress of the surgery. Sometimes we are using nephrotoxic medication as non-steroidal or antibiotic, some kinds of antibiotic. So all of these decrease renal blood flow, and as a reflex, renin-angiotensin-aldosterone system will be activated, and this causes decrease renal perfusion and ended by kidney injury. And for critical care, little bit difference. There's another pathophysiological mechanism, and of course, if you have septic shock patient, vasodilatation, hypotension, decreased cardiac output, all that will reduce renal perfusion and cause injury. But also in the small bowel, there's a penicillin activated during the sepsis, so that will release interleukin factor 17, cause damage to the intestinal mucosa, translocation bacteria, release of the tumor necrosis factor, interleukin 6, and cause multi-organ failure, including the kidney. So why the acute kidney associated with high mortality? Because it's not problem in the kidney only, but other organ affected as well. So for the central nervous system, you have autonomic encephalopathy, increased intracranial pressure, altered cerebral perfusion, increased volume overload, increase cardiac demand as well, increase risk of the pulmonary edema, ARDS, volume overload, impair the immunity, liver congestion, affects pharmacodynamic. Some you have limitation of some medications as well, which is important for us in intensive care. So that's why it's quite important to try to prevent acute kidney injury, as we mentioned earlier. So we have to prevent acute kidney injury, you have to know the risk factor and susceptible patient. So some patient already susceptible for acute kidney injury, like patient already in chronic kidney disease, CKD, diabetic, cancer, patient with anemia, dehydrated. Those are already from the beginning at risk of the acute kidney injury. If they're exposed to one of the severe insults like major surgery, trauma, non-cardiac surgery, nephrotoxic medication, so the acute kidney injury chance will be high. So that's why we have to stratify our management based on the susceptibility and exposure of our patients. So some patients at risk of the kidney injury, based on these two factors, we have to individualize our management. So we have to optimize their blood pressure. We have more frequently to check their urea and creatinine. So acute kidney injury can be classified into 3 groups, as we know, as all the classification, as all of us know. So either pre-renal or post-renal or intrinsic. Pre-renal, which is mainly due to decrease in blood flow. It might be due to hypovolemia, either absolute hypovolemia, like bleeding, or relative redistribution of the fluid, like pancreatitis, peritonitis, or burn patient, or decreased cardiac output for any reason, for myocardial dysfunction, valvular problem, arrhythmia, or decreased systemic vascular resistance for anaphylaxis, for example, for anaphylaxis or septic shock. Post-renal due to obstruction, whatever the cause of the obstruction. Intrinsic, this is a problem in the renal, either acute tubular injury, nephrotoxins, interstitial disease, lupus, connective tissue disease, or if prolonged pre-renal, ended by the ischemic damage to the renal tubules and converted from pre-renal to intrinsic acute kidney injury. So in intensive care, you have, or when you have patient, you have to recognize which problem, where is the problem exactly. It was pre-renal or intrinsic. Pre-renal is you have to optimize renal blood flow, optimize cardiac output, optimize volume status, optimize perfusion and pressure. So you can do it with simple test, just urine analysis, look for the specific gravity. If it's pre-renal, the urine will be very concentrated because the kidney tried to maintain fluid to compensate for the hypoperfusion. So if the specific gravity is high, more than 1.020, this is really suggesting pre-renal cause. If urine sodium less than 20, also this is pre-renal cause because the kidney tried to maintain sodium. And if the intrinsic, concentrating ability of the kidney already lost. So the kidney cannot retain fluid anymore, cannot retain sodium anymore. That is why the specific gravity of the urine will be very, very low. And also urine sodium will be very, very high. It's more than 40. Same for fraction excretion of the sodium and for fraction excretion of the urea. It will be low in the pre-renal and high in the intrinsic. If you look to the osmolality, the same. Osmolality is high in pre-renal. It will be low in the intrinsic. So also renal microscopy might help us to differentiate between different types of the intrinsic renal disease and pre-renal as well. There's we cannot go through that in details, but this is a summary how to differentiate between pre-renal glomerulonephritis, acute interstitial nephritis, acute tubular necrosis, bionephritis, rhabdomyolysis to the urine microscopy. KDIGO, what means KDIGO? Kidney disease improving global outcome. This is a big institution to try and the largest institution dealing with kidney disease and looking for how recommendation to prevent or optimize recovery of the kidney. So they have bundle. They recommend optimization of the hemodynamic and volume status. They recommend functional hemodynamic monitoring, urine output, and creatinine monitoring, avoiding nephrotoxin. Glycemic control also is recommended by KDIGO. Alternative to radio contrast whenever possible, and discontinue ACE inhibitor when patient will have acute kidney injury. This is the bundle showing improvement outcome. Now we're going to go for important aspect on this in this bundle. So first of all, when optimizing with NF, we're looking about the pressure and flow. So we're going to talk about, before going in details, let us go about perfusion pressure and glomerular filtration rate. So in normal condition, when MAP our MAP is acceptable within normal range, so the blood flow through to the glomerulus will be normal, and we don't have any issue regarding glomerular filtration rate. So as soon as blood pressure drops a little bit, what will happen? Prostaglandin mediate afferent vasodilatation to decrease renal blood flow, and angiotensin mediate afferent vasoconstriction. So that maintain filtration pressure and glomerular filtration rate will be maintained. If the blood pressure, if the hypotension is severe, persistent, what will happen? Will be vasoconstriction because of afferent and efferent, because renal sympathomimetic and increased angiotensin 2. At this time, glomerular filtration rate will be reduced. Same thing would happen with ACE inhibitor. ACE inhibitor will be losing decrease angiotensin 2. So both afferent and efferent will be dilated, will not respond to the change in blood pressure. So for that, to maintain good normal filtration rate, you need a little bit higher blood pressure. So if you have patient on ACE inhibitor, when it comes to theater, keep in mind you need good perfusion pressure for this patient to prevent acute kidney injury. The same thing for the patient, if you're using non-steroidal in operating theater, like ketorolac as analgesia, keep in mind that non-steroidal will inhibit the decreased vasodilation effect of the prostaglandin. So in this case, you have to maintain good perfusion pressure. So hypotension definitely will be harmful for such patient. You can use it. You can use non-steroidal, but you have to keep in mind you need to keep good perfusion pressure for your patient. You have to avoid hypotension at that time. The same thing for the patient with long-standing hypertension will be atherosclerotic. So the vasodilation property of the afferent is not there. So you need to keep high blood pressure to maintain their perfusion because they cannot compensate like other population. So what's the best perfusion pressure? So this study, systemic review, looked for the trial from the inception to 2022, looks for the the best evidence during this time. So after analyzing, they found they ended by 12 randomized controlled trial, and they included 5,759 patients, and divided the patient into 3 categories. So the first category, patient with shock, and they compare between the MAP 65 to 70 or more than 70. So in this group, it's about 57% of the total population of this systemic review, including 2,082 patients, and 1,687 patients, which is patient exposed to non-cardiac surgery. They compare between MAP 60 to 75 or more than 75, and those people non-cardiac surgery group, or surgical cardiac surgery compare between blood pressure 40 to 60 and more than 60, which are 790 patients. What they found in the patient was shocked patient, septic shock patient. In this group, they found no difference between keeping MAP less than 70 or more than 70 in terms of the risk rate of the acute kidney injury or rate of the requirement of the renal replacement therapy on both groups, except if the patient chronically hypertensive. If the patient chronically hypertensive, they found the keeping MAP more than 70 associated with better outcome or low risk of the acute kidney injury. So patient for the second group, which patient non-cardiac surgery, they compare between MAP less than 75 and more than 75. There's found no difference between both the group in terms of the acute kidney injury, rate of the acute kidney injury, or requirement of renal replacement therapy. They tried even subgroup analysis comparing between MAP normotension and normotension, or 75 to 90, 95. There's no difference in outcome between the 2 groups in terms of the renal requirement of the renal replacement therapy or incidence of the acute kidney injury. In cardiac surgery, also between MAP between less than 60 or more than 60, there was no difference in the rate of the acute kidney injury and rate of the renal replacement therapy. So they came concluding targeting MAP in shock or perioperative patient, higher MAP may be not superior to normotension, except if the patient already hypertensive. In this stage, they need a little bit higher MAP. How high? We don't have strong evidence to mention to determine this the better MAP. So expert opinion recommend keeping MAP 65 all the time is needed. Try to minimize hypotension as much as you can. if the patient already, the risk of the acute kidney injury is high, or already have acute kidney injury, try to keep MAP within 10% from the baseline. So in this study is very interesting study showing a retrospective study, included 16,000 patients, and look for the association between using buprenorphine and post-operative acute kidney injury. So despite maintaining good MAP within the target, but the incidence of the acute kidney injury is high in the phenylephrine group. So because the pressure doesn't reflect the flow, so you maintaining MAP without maintaining intravascular volume or good cardiac output is not enough. So you have to keep intravascular volume and maintain good cardiac output as well. This study recently published in 2023, and they recommend you have to optimize intravascular volume and also cardiac output. So when you talk about the fluid, first of all, we need to determine which volume we need to know. We need to use which fluid you need to use, and the volume you need to give. So it's a long discussion between sorry. So if you look to on the right side of the screen, this graph here. So there is 0. This is the neutral. If we go to the right, this will be the benefit. We go to the left, will be the harm. The x-axis showing our confidence in the statement, how we are sure about our statement. So there are many studies comparing between different types of fluid. So we have, I think since almost 10 years, we are talking about harmful effect of normal saline, hypochloremic acidosis, effect of the kidney function, effect on the mortality. So this is systemic review, compare between balanced, crystalloid, and saline in critically ill patients. This systemic review included 34,450 patients. And they found no statistical difference between the two in terms of the mortality or acute kidney injury or renal replacement therapy. Of course, we as intensivists or in critical care, we don't like hypochloremic acidosis because that might affect, might cause hyperkalemia and might have other effect as well. So it's better if it has the same effect. We're going to go definitely for balanced solution is available. So if you put it in the curve here, then you see azotonic saline slightly toward harm side. It's better to be buffered crystalline solution. So if you need to give a resuscitation fluid, you have buffered, use buffered solution. If you don't have buffered solution, you can use normal saline. The other, regarding the colloid, the chest trial tried to see the study the harmful effect of the hydroxyethyl starch, and they found this increased mortality, increased acute kidney injury and renal replacement therapy. So hydroxyethyl starch is not used anymore, so it's banned already. Regarding gelatin, the study showing it's harmful. So it's increase the risk of the kidney injury, mortality, anaphylaxis, and bleeding. So it goes to the left side of the curve. So what are the best colloid is the albumin. Albumin in the safe albumin trial, no difference in urine output, organ failure, and duration of renal replacement therapy between saline and best albumin solution. So if you need to use colloid, you can use albumin. Except in a brain injury patient, so albumin is not recommended. And if you look here to the curve as well, you need mentalist fluid going to the left side, to the harmful side. If the patient already taken orally by the NGT, enough calorie, so don't give maintenance fluid for him because that will be accumulate in his body. He will be overloaded. Low volume resuscitation is superior to high volume resuscitation. High volume resuscitation always associated with poor worsening in outcome. So as we know, the fluid management, we know that hypovolemia is the most major risk for the acute kidney injury. We know that oliguria is the most trigger for the fluid administration, but fluid is a drug. increase the workload of the kidney, increasing sodium chloride filtration and reabsorption, increase oxygen and ATP consumption in the renal tubules. So also can increase oxygen demand and can worsen the outcome of the kidney. So persistent fluid administration to increase urine output is likely to be harmful to your patient. So in one study showing associated between mean fluid balance over 24 hours and acute kidney injury, the strong association. So fluid balance might be harmful into your patient. Why that? Because increase the too much fluid balance, increase over resuscitation fluid, and cause increase the venous pressure, decrease the intrarenal pressure gradient between artery and vein, so that increase renal blood flow. Also increase the interstitial and tubular pressure and decrease the glomerular filtration gradient between the glomerulus and the renal tubules, so that the filtration the filtration pressure will be decreased, and so the GFR will be reduced as well. In addition, too much fluid resuscitation will decrease cardiac output. That will decrease venous return as well, and decrease renal blood flow. In addition, too much fluid resuscitation also can cause compartment syndrome, will decrease venous return and decrease cardiac output, and ended by decreased renal blood flow. So there's one study called a classic trial, and comparing between restricted fluid resuscitation and standard care protocol. So they included only 150 patients, a small group of a small population. And the restricted group, they give fluid only after initial phase of the resuscitation. After the first 24 hours, they give normal fluid resuscitation, 30 ml per kg. Then after that, they restrict the fluid. They give only if the lactate more than 4, MAB less than 50, mottling beyond the edge of the kneecap, or oliguria. And the standard group, they give fluid as they are as circulation is improving. What they found in the first 24 hours, the median volume taken by the resuscitation fluid restricting group is 500, while in the standard group is about 1,300. But the urine output almost the same between the two groups. So the over resuscitation didn't help actually improving urine output. But if you look to on the mortality in the down in the curve little bit, on the right curve, there's no difference in mortality between the two groups. If you go to the sub-analysis here, death by 90 days, 25/75 in the restriction group, and 31/76 in standard group. So the mortality a little bit higher in a standard group. Ischemic event, 3 in restriction group, while 9 in 3/75 in restriction group, and which is equal to 4%, and 9/76 in the standard group, which is almost 12%. And worsening acute kidney function, acute kidney injury, is statistically significant in this part. So the restricted group is better outcome in terms of the acute in terms of the acute kidney injury. So the trend, they prefer restricting fluid resuscitation rather than the standard rather than liberal fluid resuscitation. So if you see here, there's the trend toward the benefit toward the restricted, but because the sample size is small, it wasn't statistically significant. Maybe if the sample size is bigger, it will be that the outcome will be much clear. So in this curve here, there's the X here looking for the probability of non-recovery for the kidney from the acute kidney injury and net fluid balance. So X will be net fluid balance, and Y is the probability of non-recovery. Too much negative balance decrease the chance of the upper curve for in the first 24 hours, the upper curve for 48 hours. So too much negative balance decrease the chance of recovery of from the acute kidney injury. Too much fluid balance, positive fluid balance also decrease the chance of the kidney recovery from the acute kidney injury. So it's better to keep within 1 liter positive, 1 liter negative is acceptable, and or maximum 2 liter. But more than this, either positive or negative will be very harmful. The same thing for in the 48 hours. So as if the fluid balance more than 5 liter, the chance of the recovery, probability of recovery increases significantly, reach up to 1% if it's more than 12 liter positive. So that goes take us to the 4 stages of the fluid resuscitation. If we look to the curve here, cumulative balance, fluid balance, and the down curve is the 4 organ failure. So we have 4 phases in a fluid for fluid therapy. The first phase is called resuscitation phase. The second phase is optimization phase, then stabilization phase, then evacuation phase. So in the resuscitation phase, we know the septic patient, vasodilation, leaking of the fluid interstitially. So we know that very clear the patient requires fluid. So no doubt we have to be generous with this patient in this time. So giving the fluid in our phase, which is resuscitation phase, is needed as recommended by the sepsis campaign. So if you look to the down curve, during this phase, you give fluid, you decrease organ failure. Then in the second phase, when you finish the resuscitation phase, now it's some patients will still need fluid, and so these patients we have to assess their volume status with each bolus you are giving to your patient to avoid overload. So now if you look to the down curve during O phase, optimization phase, if you give more fluid, organ failure to start to rate of the organ failure start to increase. During the stabilization phase, this time you have to consider keeping your patient on negative side. So don't give any extra fluid to the patient already stable, unless clinically indicated. If your patient had a stoma, significant fluid loss, then that time you need to give fluid. Otherwise, you don't have to give him fluid. But the stage patient need to be considered toward avolemic or negative side. Then last phase after stabilization phase is evacuation. Now the patient is stable, and now you have to clear him from the extra fluid you are giving. For daily start, evacuate extra fluid to enhance his recovery. So how much you need to take from this patient? Actually, it's very difficult to determine. So we need to check fluid responsiveness. We have to continue using the patient and check fluid responsiveness. When the patient becomes fluid responsive, then stop. This is the time you have to stop. And also this bring us to the other aspect, very important aspect. You have to consider hemodynamic monitoring when you are dealing with patient, critically ill patient and patient at risk of the acute kidney injury. So there's one study called Vidora study, prospective multicenter trial, looked at the effect of goal-directed hemodynamic and outcome. This included 450 patients. They used transvagal Doppler, and either control group receiving ringal lactate 3 to 5 ml per kg per hour for laparoscopic surgery, and for open surgery 5 to 7 ml, or using hemodynamic monitoring, including measurement by transvagal Doppler. They are measuring stroke volume to check the fluid responsiveness, and cardiac index and MAP. Initially start with giving 250 ml of the fluid. If the patient's stroke volume increased by 10% with this 250, they give another 250 ringal lactate. If he's still responsive, they start giving volumen, hydroxyethyl starch. If no fluid responsiveness anymore, they look for the MAP and cardiac index. If the cardiac index is more than 2.5 and MAP less than 65, they use vasopressor. If the cardiac index less than 2.5 and MAP more than 65, they use inotropes. The outcome complication is less in cardiac hemodynamic, cardiac directed goal directed hemodynamic therapy, and kidney injury also less. But in other complication, length of the stay or mortality, there's no difference between the two groups. Interestingly, both group that received the same volume of the hydroxyethyl starch. But the point is, time with intervention is important. So I think considering using vasopressor or using inotropes on time definitely made a difference in the goal directed hemodynamic and reduces the chance of the acute kidney injury. The other important aspect we normally face in our daily practice, blood transfusion and acute kidney injury. So this is in this study they looked for the acute kidney injury after cardiac surgery. So this is they included 3,500 patients underwent different cardiac surgery at 7 cardiac academic cardiac hospitals. So they found severe anemia associated with the increased preoperative anemia associated with acute kidney injury. So as soon as the hemoglobin less than 12, every gram decrease in hemoglobin increase risk of the acute kidney injury. So in pre-anesthesia clinic, you have to optimize, you have to make sure you treat preoperative anemia before going for the major surgery. For intraoperative blood transfusion, there is increased risk of the acute kidney injury according to the amount of blood you transfuse the patient. If you give 5 units, acute risk of the acute kidney injury almost 10%. So if you give 10 units, the risk of the acute kidney injury almost 20%. So as soon as you there's strong association between acute kidney injury and amount of blood transfusion to the patient. So is there a rule for steroid to improve mortality or improve or prevent acute kidney injury? In this systemic review, and looked for the almost between they collected the best evidence between 1998 and 2018. They included 20 studies and looked for the the difference between an outcome between the two groups. So Lasix itself has neither impact on mortality nor has no impact on the requirement of the renal replacement therapy. So the steroid doesn't prevent acute kidney injury and is not improving the mortality. And KDIGO recommend users only to prevent acute to treat overload, but not shouldn't be used to prevent acute kidney injury. As we mentioned, no rule for enhancing recovery from the acute kidney injury. The other important aspect, timing of the patient. If I got patient with renal replacement therapy now, so what's so when I need to do dialysis for him, early dialysis or late? In this study, in this randomized controlled 2 studies together included 1,465 compare doing dialysis within 12 hours or wait till up to our late group within 72 hours, and they look for mortality between the two groups. So there's no difference between the outcome if you do dialysis early or late. So we don't recommend doing dialysis unless clinically indicated. You need to rush to do early dialysis if the patient already got acute kidney injury. So what the other study now, the other topic is very important to what I need to do for my patient. I should go for continuous renal replacement therapy or intermittent renal replacement therapy. So the same population in the previous study, comparing early and late dialysis, the same population, the same data from this study, they tried to they do subgroup analysis, and they compare between the people already had intermittent replacement therapy and the people they have continuous replacement therapy, and look for the outcome. And they found there is no difference in outcome between the two groups in terms of the mortality. But actually, if you look for if you have critically ill, the comparison wasn't fair, because most of the people requiring intermittent replacement therapy in these studies were critically ill in terms of the hemodynamic. They have cardiac issue. They have severely and requiring high dose of vasopressor. So this is major limitation in this study. When you have critically ill patient on vasopressor, he cannot tolerate removing 3 liters of the fluid over 3 or 4 hours. If you have critically ill patient on vasopressor, it's better to go for intermittent renal replacement therapy and avoid continuous renal replacement therapy and avoid intermittent, because hemodynamically will not be stable to remove 3 liters from your patient. So in anesthesia, we know that epidural improve the increase vasodilation, increase the visceral blood flow. So on this study, looked for the effect of the epidural in abdominal aortic aneurysm on the mortality and acute kidney injury. So actually, epidural reduce, it was associated with better outcome in terms of mortality, better mortality, and better in terms of the acute kidney injury. So it's highly recommended because this is increase the subclavian blood flow. So what about dexmedetomidine? Dexmedetomidine, it has been used in all, I think, on all aspects of intensive care and in anesthesia. You use it for pediatric, for adult, for sedation, for in the critical care as well, to control agitation. And they found it promote blood flow via inhibiting vasoconstriction, promote diuresis, because decrease renal arginine, protect the kidney ischemia, reperfusion injury, decrease systemic inflammatory response, reduce the renal cell death, and the cardiac surgery. It's a very interesting study here, and actually meta-analysis including 19,266 patients, and between and they include 4 cohort study and 3 randomized control trial. They found it's in cardiac surgery patient. They use it small dose, 0.5 microgram per kg per hour, and they use it for almost 4 to 5 hours. And they found this improve the kidney function and decrease the risk of the kidney injury if they use it in the cardiac surgery. But unfortunately, they didn't decrease the duration of mechanical ventilation, they didn't reduce hospital stay or ICU stay or mortality. So last topic we want to talk about today is contrast-induced nephropathy. As a definition, increase the serum creatinine 0.5 milligram per deciliter or 44 micromole per liter, or 25% increase from the baseline. Assessed at 48 hours according to the KDIGO, or 72 hours according to Society Urogenital Radiology. There are 2 definitions here. In KDIGO, they consider increased serum creatinine 0.5 or 25% within 48 hours is the contrast-induced nephropathy, while Urogenital Radiology Society consider increase the creatinine over 72 hours considered as a acute kidney injury. The good thing is most of the times it's reversible and return back to baseline within 10 days. KDIGO recommend exclusion other cause as well. The incidence decrease from 15% over to 7% over the last 10 years. I think because we are more aware about the risk of the acute kidney injury and optimization and type of the contrast we are using now. So what happened exactly? So when you have patient at risk factor of the acute kidney injury, either diabetic or already impaired kidney function, already reduced number of nephrons. When you give the contrast already cause endothelium independent transit vasodilation inside the kidney. As a response, will be adenosine will be released from macula densa, which is called sustained intrarenal vasoconstriction. So they keep the contrast inside the kidney for hours, increase that endothelial release, prostaglandin dysregulation, so decrease nitric oxide. So the contrast is stuck in the kidney, and already vasoconstriction decrease in blood flow. So ended by medullary hypoxia and prolonged contrast transit time, which is increased the risk of damage of the kidney. So we ended by the kidney injury. So how to prevent? Before prevention, we need to know the risk factor and how to optimize our risk factor. So some risk factor is modifiable. Contrast volume we can control in the volume. Hydration status. If the patient already dehydrated, we have to optimize his volume status before. Avoid nephrotoxins. If he received already contrast, so we try to delay the contrast other hit till the kidney recover completely. Non-modifiable factor, you cannot do much for it, like diabetes, CKD, advanced age. So that we have to wait risk and benefit from the going to the contrast. So this is very good scoring system. It's used for the coronary angio, but can be used for the other problems as well in the critical care, called Mehra risk scores. So they include all the risk factors and they give point according to the importance. For example, if a patient hypotension, he will give 5 points for this one. If the patient intra-aortic balloon pump, we are not using it anymore, but as I told you, this is for the coronary angio patient, we'll give 5 points. If patient congestive heart failure, will be 5 points. Age of the patient more than 75 will be 4 patients. So even the contrast media volume, each mil, each 1 point for each 100 mil we are giving to this patient. Serum creatinine as well, it's more than 1.5 milligram per deciliter, or estimated GFR for my patient. So that will help us to estimate the risk of the acute kidney injury and the risk of dialysis as well. If the risk score less than 5, the risk of the acute kidney injury will be 75% only, and risk of dialysis 0.04. So that helps us also to help our patient to take a decision. Because we have something little bit objective rather than subjective to tell them, according to the score, the chance of having kidney injury will be, according to your score, will be this number, and chance of having dialysis will be this number as well. So that will be, the picture will be very clear for the patient, and you can make a decision based on this data. So how to reduce? As I told you, the reduction but not prevention. Volume expansion is very important. So we'll start with hydration 1 to 1.5 ml per kg per hour, isotonic normal saline or sodium bicarb, isotonic normal sodium bicarb. So isotonic sodium bicarb will take 154 ml of 8.4% of sodium bicarb mixed with 1 liter sodium dextrose 5%, and we start infusion 1 to 1.5 ml per kg per hour. Fluid should be started 3 to 12 hours before and continue 6 to 12 hours post-exposure. Our target to achieve urine output 150 ml per hour for 6 hours post-exposure. We need to stop diuresis. We need to stop nephrotoxin. And if there's alternative to the contrast, we have to consider you have to use lowest volume, non-ionic, non-smolar contrast. No rule for renal replacement therapy or dialysis after exposing to the contrast. Actually, you're exposing the patient to the other hit. Already he got hit from the contrast. When you do dialysis, the patient will be hypotensive. He will get another hit from dialysis, and you might decrease his chance for recovery. So, in summary, for our talk today, even minor change in reduction in kidney function has adverse prognosis. Early detection treatment may improve the outcomes. Unjustified fluid administration may worsen the kidney function. Proper assessment, volume status, and advanced hemodynamic monitoring should be considered if you have critically ill patient. Management of the acute kidney injury should focus on implementation of the intervention to prevent its development, providing supportive care to prevent further injury and facilitate renal recovery and to treat complication. I came to the end. Thank you very much for listening. I'm happy to take your questions.
Thank you so much, Dr. Adil. Thank you. Very fascinating lecture, and you delivered it in a very comprehensive and simple way. Thank you very much. Thank you, Dr. Adil. Really, till the
Thank you, Dr. Adil.
We are waiting for your question, my dear colleagues. But Dr. Adil, I have comment. Just from conclusively that if we predict, we will prevent. If we predict acute kidney injury in certain patient, for example, because I am biased to pregnant patient, if my patient is uncontrolled hypertension or severe preeclampsia, or this pregnant lady come in trauma and sepsis like that, I should keep my eye open upon her fluid management, serially monitored the kidney function, serially monitored her blood pressure to avoid the bad end result, which is the acute kidney function. I am right, Dr. Adil?
Yeah, definitely. That's why I share that susceptibility and the exposure. So if you know which one's susceptible to the kidney injury, and he's going to expose to the major insult, you have to be very vigilant with your management. You have to optimize their blood pressure, hemodynamic, volume status. So you have to do everything to prevent kidney injury. Because we don't have any treatment for the acute kidney injury, only supportive care and waiting for the kidney to recover.
Yes. And also to avoid more adding iatrogenic factors for my susceptible patient or vulnerable patient. I should keep my eye open, because also, as you know, Dr. Adil, that when one organ fails, of course, there is inter-organ crosstalk, and we may have more complication and go in a black street and a black tunnel, and we couldn't control the issue. So if we predict, we will prevent. Dr. Adil, our colleague, Dr. Dunya, asked a question. Why no role for RRT for nephron CIN?
Because contrast there is no evidence for that. With the study showing sometimes, most of the times, the contrast is not dialyzable, and the study showing no improvement in outcome. The outcome might worsen. So there is why no point to do dialysis, because if you do, as we describe it here, the contrast already in the kidney and already causing vasoconstriction and decrease the blood flow. So the kidney already got pre-renal. And when you do dialysis after the contrast exposure, you will cause hypotension. You are worsening the pre-renal status of your patient. And the contrast already non-dialysable, and the study is not showing any benefit from dialysis. So why you are doing something? It might be harmful, and no evidence for that.
Yes. Dr. Adil, from your experience and after your comprehensive lecture today, what do you suggest? The critically ill patient developed acute kidney injury have more good prognosis than the acute kidney injury in perioperative period? Which one will win the race, and which one will respond dramatically or respond in the right way for our management?
The point in critical in ICU, most of the patient he when he has kidney injury, he got other problems as well most of the times. So you will not find in patient in ICU just for acute kidney injury. He got multi-organ failure as well. So that is why they are quite complicated. While in theater, sometimes patient got kidney injury but hemodynamic stable, he just go to ward and recover. So definitely patient in critical care, he will be more sick, more critically ill, and management will be difficult. And but in sometimes even in the critical in theater, and sometimes patient we had a patient already hypertensive, no case of the CKD, and sometimes they come for the procedure like laparoscopic cholecystectomy. He become hypertensive for a while, and the second day he will be clinically looks normal, and we send them, we look for the creatinine became normal, and we find it's normal, we send him home. But actually creatinine start to rise after 48 hours. No one will recognize he got kidney injury or not, because we're discharging patient second day. And this but in ICU the situation completely different.
Dr. Adil,
Dr. Adil, we have one question also.
Yeah, Dr. Ahmed, from Dia.
He is asking. Yes.
Yeah.
Yes. I have a comment regarding the unjustified fluids administration. As you know, in the critical care, we have a lot of patients admitted to the ICU with the septic shock, and there is sepsis-induced nephropathy, and we need to give fluids. So very important to monitor. I want to ask you, what is the rationale behind unjustified? We need the patient to be eovolemic, or we must give a lot of fluids. And also the question, I will add the question of my colleague, which is preferred for the IV fluids, ringer lactate or the normal saline, in the acute kidney injury in general, and in the septic patient admitted to the ICU with acute kidney injury.
So thank you very much. This is very good question actually, and I'm waiting for this question from before starting even the presentation. So in terms of the fluid, this slide summarize safety of all kinds of the fluid we are giving to our patient. So balanced solution definitely superior to normal saline. Although the study last systemic review shown there's no difference in terms of the acute kidney injury or mortality or renal replacement therapy between balanced solution or buffers or ringer lactate and normal saline. But normal saline definitely, as when you give it at large volume, can cause metabolic acidosis, hyperkalemic acidosis, which is we don't want this kind of complication in our patient, because it has another consequence in our patient as well. It can cause hyperkalemia, can change the pH of your patient, so it will affect metabolism of many medications, and also affect oxygen hemoglobin distribution curve as well. So actually, normally we prefer the patient in neutral pH status. So if it comes to the if you have buffer solution ringer lactate, go for ringer lactate. This is the best, or balanced or plasmalite. So definitely it's superior. Regarding the fluid, what you need to give in initial phase of the resuscitation. If we look to this slide, it's very obvious that this patient is requiring a large volume of the fluid because of facilitation and because of redistribution of the fluid. So you need to be generous with him. You don't have to assess hemodynamic or assess volume status when you have severely patient in severe septic shock and he's severely hypotensive. But at certain stage, when you reach 30 ml per kg, then you have to consider continuous volume status assessment and check the fluid responsiveness of your patient. If the patient is not fluid responsive, don't give fluid anymore, because the fluid you are giving to the patient will be harmful for him. It will be causing multi-organ failure and will be worsen the kidney function, and you will struggle to evacuate this fluid from your patient. So in the initial phase, in our phase, this is the resuscitation phase. In the first 3 hours, you can give the volume, but as soon as you give a certain amount, which is recommended by the sepsis campaign, then you have to think twice before giving a fluid. You have to check the fluid responsiveness. If we have different techniques to check the fluid responsiveness, you can use leg grazing test, pulse volume variation. If the patient fluid responsive, start giving you fluid. This is during the optimization phase. When patient is stable, don't give the fluid anymore. And during evacuation, when you start after 4 or 5 days, when patient becomes stable, sorry?
Yeah, maybe someone unmuted.
Okay.
Accidentally, yes.
Yeah, okay. So as soon as patient you're stable, then you start evacuation fluid. You start diuresing. You're targeting negative balance daily till patient recover. So how much you need to evacuate, how much you need to diurese, then diurese till patient become fluid responsive. When patient becomes fluid responsive, stop, don't diurese anymore, because now extra diuresis will reduce cardiac output and will be harmful for your patient.
Yes.
I hope I answered your question.
Yes. As you mentioned,
you.
Dr. Adel, fluid is a drug. So
yes,
should be carefully used, and we should guide our resuscitation, fluid resuscitation by many methods: hemodynamic, ultrasound, echocardiography, to enhance Nebras Buhara program to use.
yeah.
Yes. There is a question from one of our colleagues about using oral fluid for patient before contrast as IV fluid regimen in outpatient procedure for CT or for CT with contrast. He asked about oral.
The recommendation intravenous, because the volume is 1 to 1.5 ml per kg per hour, which is about, if someone is 70 kg, so he needs to take 100 ml per hour. So, and they need to start 3 to 12 hours before contrast exposure. So we prefer IV. The recommendation is intravenous, not oral.
Yes, yes.
Dr. Adel, someone is asking about the role of diuretics, Lasix in the acute kidney injury, and also I will add about the role of sodium bicarb. You know that there is some colleagues, and he is very going على طول to give giving sodium bicarb to the patient with acute kidney injury. From your experience, what is the role of Lasix or diuretics in general, and the sodium bicarb in the acute kidney injury?
Lasix, according to the KDIC recommendation, does not facilitate recovery from the acute kidney injury, which help to control of the overload. So I like Lasix, and I found that Lasix is very useful in intensive care. I use it, and I prefer. So during if you have kidney injury, if you find your patient already overloaded, giving Lasix, it might help kidney to recover. But you need to assess volume status first. Your aim, not to enhance kidney function, but your aim to control the overload. So I'm going to give a quick example here. So one week, I was in our intensive care. So we had a patient who had a major surgery, and she got acute kidney injury. And I came to assess the case, and So when we assessed volume status, volume status of this patient, she was positive 5.7 liter cumulative balance over 1 week. So we know that now the volume overload contributing in her kidney injury. So we're using Lasix to control her overload, and then kidney function recovered. Because and we see that even sometimes we do dialysis once to the patient. After that, he starts passing urine and kidney function starts to improve. The dialysis we did once, we decreased the congestion of the kidney. That's why kidneys start to work. The same idea for Lasix. Sometimes giving 1 dose of Lasix just to decrease the congestion, but you have to be sure that the patient already overloaded. You have to look for volume status of your patient over cumulative balance, not just 24-hour balance. You have to look for 5 days, 6 days, 7 days balance. If he is too much positive, then definitely, yes, Lasix might help the kidney to recover because will decrease the congestion of the kidney. Regarding the sodium bicarb, if the patient CKD, we give sodium bicarb because the kidney cannot compensate for his acidosis. So yes, we give sodium bicarb. But in acute setting, we don't give sodium bicarb. I hope I answered your question.
Yeah. Dr. Adel, our colleague Dia asked another question. Does there is a rule for albumin followed by Lasix in acute kidney injury patient to increase urinary output?
Actually, as evidence, there is no evidence for that. But in last meeting in Barcelona, we had a meeting. We have discussion with expertise. Expertise recommend using albumin with diuretic.
Yeah. So can be used.
Can be used, yes.
Can be used. So I have a question, Dr. Adel. As you know, if we have, for example, postpartum hemorrhage, and we are treating our patient by fluid and replaced by fluid, blood, etc., and of course, at a time of stress, because of anesthesia, because of hemorrhage and resuscitation, always we have increased secretion of antidiuretic hormone as one of the stress hormones. So
yes.
Sometimes we face the oliguria for about some hours, maybe up to 5 hours after post-operatively. At this time, I'm convincing that as long as I have hemodynamic stability and I have stopped the bleeding and I have controlled the source of bleeding, I did sure I should be cautious when give no more fluid and give no more Lasix for such patient, as after cessation of secretion of antidiuretic hormone and mitigating the stress, of course, I will have increased urinary output. I am right in my consideration.
Thank you very much. It's a very nice question and very good question, Professor Safa. Actually, for me, I'm against using Lasix during resuscitation of hemorrhagic patient, because especially in postpartum hemorrhage patient. So because already the patient lost a lot of amount of the blood, we don't know their volume status, and already we know that renal blood flow significantly decreased at that time. So giving Lasix, you might increase the stress on the kidney, you might harm the kidney function, and you might decrease the blood flow to the kidney. I will be patient. I will wait. Yes. As soon as hemodynamic is stable, I don't rush to wait for Lasix. I can wait for as soon as he is not overloaded. I don't rush for Lasix. Patient will start passing urine by themselves, or when I'm sure everything is under control, I will assess their volume status. If they feel already overloaded, then that time I'm going to use Lasix. But during acute setting, I for personal opinion, I don't do that.
Yes. I totally agree with you, Dr. Adel, and this is my approach to all the postpartum cases that I meet frequently. One of our colleagues asked about the hypertonic and Lasix in patient is susceptible for acute kidney injury to increase renal output.
Up to my knowledge, there is no evidence for according to evidence according to the critical recommendation. No one is recommend using hypertonic saline and Lasix, and according to their recommendation, use Lasix only if volume of the patient already overloaded, but not to prevent acute kidney injury.
Yes, yes, great answer and concise the answer. Yeah, we should highlight this issue. Yeah, this is Doreen Haishi asked about the correlation between acute kidney injury and the constant anemia. We see sometimes we see patient with anemia always RBC is low. This is the red blood cells. Duran is here. Duran Hashi is here. If Duran Hashi is here, you can ask your question. You can unmute yourself.
Yes, I'm in here.
Yeah, ask your question for Dr. Adil, please.
Yes, thank you to all of the colleagues, doctors, professors. And I want to ask Dr. Adil, sometimes you see acute kidney injury, we do resuscitation, then sometimes patient develop anemia. Every time you wait for replacement of the RBC or constant anemia. Is there a correlation between acute kidney injury and the constant anemia? Why the patient always low with hemoglobin?
Thank you for your question. It's a very nice question. Sometimes if patient with low urine output, anemia sometimes is dilutional anemia because you are giving fluid for the patient and you are diluting the hemoglobin. In addition, if patient he got impaired kidney function, definitely decreased amount of erythropoietin and RBC productions as well. So this might be explained why patient is having anemia. If the patient already normal kidney function and he just acute kidney injury, normal hemoglobin is supposed to be normal or with dilution decreased by 1 or 2 grams maximum, unless you are overloaded him with too much fluid. Otherwise, there's no other explanation for dropping of the hemoglobin during acute kidney injury.
Dr. Adil, there is a very nice question from one of our colleagues. He asked about, Dr. Adil, if the patient is stable and normal kidney function, there is no need for IV flow?
In which situation? In operating in
Roma or critically ill. What he mean? I don't know. So our colleague.
If he's in ICU, the patient is in ICU.
Yeah, no, he said that before CT.
Before CT with contrast, it's better to hydrate your patient, even because you don't know how much he was fasting. You don't know their volume status, so it's better to hydrate to avoid kidney injury. It's better to have good hydration. This is recommended because the contrast itself induce pre-renal status, not because the patient is already pre-renal dehydrated, but the contrast itself induce pre-renal situation, cause initially intrarenal vasodilatation followed by vasoconstriction, so imitate like pre-renal status. If you don't hydrate them, the situation will be worsened. So it's better to hydrate them to overcome the side effect of the contrast.
Yeah, he said that IV, not oral.
Yeah, oral, he will sometimes patient will not take enough amount. You don't know how much will be absorbed. Yes. So it's better to give IV.
Yes. I asked my colleagues in the floor, do you have any more question?
Thank you, Dr. Adel, too much for this amazing lecture
Yes.
and to the point
Yes.
and very close to our daily practice in the critical care and anesthesia. Really, it's a very informative lecture. Thank you so much.
Really,
Welcome.
one of the best, Dr. Adel, one of the best. I just to mention, and I know that you are interested in artificial intelligence and machine learning, and we should use our brain to detect the vulnerable patient to acute kidney injury. If we have artificial intelligence in our theaters or our critical care, we can use and introduce our data to suspect if our patient will develop acute kidney injury or not. If we haven't artificial intelligence, we can use our brain. If we have an elderly patient with trauma and is critically ill and previously has a borderline kidney function, as we mentioned before, we should keep an open eye for our patient. The other issue, which is globally, is the climate changes and its negative impact on kidney function. So our patient coming from the hot climate area, we should inquire about their kidney function because of the hot weather may cause dehydration. This hot weather also may cause environmental pollution and food changes. So we should inquire also about the climate changes. Warm heart feeling to congratulate Dr. Adel to have this fascinating lecture and to have this warm night, and you introduce every information about very hard topic, which is acute kidney injury, in a very simple way and comprehensive manner. Thank you, Dr. Adel, so much.
Welcome all. Welcome. Thank you very much. Thank you for the invitation. Thank you a lot. Thanks a lot.
And all of us are invited for the next time in Libya, in Tripoli, to attend your conference of Libyan Society, inshallah.
Welcome. Welcome. Definitely.
Thank you,
Jazakallah
Dr.
khair.
Adel.
Thank you. Thank you. Thank you.
Thank you so much.
Thank you.
شكرا دكتور عادل، الله يعطيك العافية. شكرا، ما قصرت. شكرا، تسلم. مع السلامة.
السلام عليكم. السلام عليكم. السلام عليكم.
السلام عليكم. السلام عليكم. السلام عليكم.